session. Next, we have Dr. MARIAN PAULY. She is the HOD of Oculoplasty Orbit and Ocular Oncology, Giridhara Institute. She needs no introduction. Welcome, ma'am.
Yeah, hi. Last session, Okay, this is socket reconstruction. Okay. Introduction is like, it's a broad terminology. It includes like modification of the prosthesis, surgical, and then combined, both surgery and modification of the prosthesis. So this is stock shell modified to customized. So coming to the principles of socket surgery. So either we have to replace the mucosal lining, or you have to correct the volume and make the fornices. Sometimes all the three has to be done in some of the cases. So this is first a fornix forming suture. Here patient not really bothered about the volume. Lining is adequate. He just wants the shell to be fitted in. So in that case you can get away with just a simple fornix forming suture. So suture start from the fornix. You can pull tie over the bolsters and come to the skin side. This I'll show in the mucous membrane video. So next is replacement of lining. So in this case, here also the patient's expectations are very less. He just want a prosthesis to be fitted, but without adequate lining, it will not stay. So I just did a mucous membrane graft, and then prosthesis was fitted. So why mucous membrane graft? It's easily accessible, and the donor site will easily epithelialize in 2 to 3 weeks time. The only thing, we have to be very careful when you take this thing, because you have to avoid damage to parotid duct. This opening is opposite to the upper second molar tooth when harvesting a mucous membrane graft. This is a short video. Some days we do under local anesthesia also. General anesthesia is not really mandatory for a mucous membrane graft. After marking submucosal infiltration, then I use a number 15 blade. Problem with the cauteries induces scarring, and you will not get the correct plane sometimes. Then the mucous membrane graft is lifted up. Take care, don't include too much of submucosal tissues. If you're taking too much of submucosal tissues, sometimes if you go deep, numbness will happen. Then defect the mucous membrane graft. And if it is a small defect, just suture it with the Vicryl 50 or 60. So nowadays I mostly use amniotic membrane with glue, and it is very comfortable for the patient. So coming to the socket, incision with number 15 blade. If possible, don't use too much cautery. Then dissect. Reach the fornix. Dissect both sides, superiorly and inferiorly, and keep the mucous membrane graft, and then suture it. And you have to take the fornix forming suture also. The suture should pass through the periosteum, and tie over bolsters. This our skin suture, either you can bury it, if you can put a small incision on the skin and bury inside. Then in that case you have to use an absorbable suture. Here I'm taking proline, so I'm just tying over the skin. Postoperatively, avoid hot and spicy food, antiseptic mouthwash. I usually keep the bandage in the socket for 5 days. Oral and systemic oral antibiotics, prosthesis after 6 weeks. So these are the few patients fitted with customized prosthesis after mucous membrane graft. Complications are extremely rare. While I was using suture to close the mucous membrane area, I was getting 1 or 2 granulomas. But nowadays I mostly use amniotic membrane, so not much problems. Orbital implants, we have heard from Dr. Anju, can be primary or secondary. So primary she has already shown following enucleation evisceration. Coming to the secondary implant, so this is a lady, the contracted socket. So what we have done, a secondary ball implant with the fornix forming sutures and fitted with a prosthesis. Similarly, this is a gentleman He had formic acid injury with had extensive formic acid injury, so presented to us with nectropion, then an anophthalmic socket. So first we corrected the lid, and then we reconstruct the socket with a secondary implant. So coming to dermis fat graft, it can be primary, young patients, conjunctival scarring, secondary after extrusion or exposure of the implant. Here the thing is, like, sometimes results are not really predictable. I'll show some cases after this video. So video, I think I will skip, I think, no. So here is a primary, this is a trauma, then repair done, phthisis. So now actually I'm moving away from implants because I did dermis fat graft for her. I fit her with a prosthesis. The only thing, this little bit of superior sulcus deficit, but patient is not really bothered. So this is 18 months. She presented to us at 18 months. Left eye microphthalmos. You can see they were not very willing for any procedure considering the expectations for vision. So initially we started with customized prosthesis. Then by 3.5 years, she underwent dermis fat graft and followed by customized prosthesis. So this is another patient, again trauma. All cases need not require evisceration. In fact, they came for evisceration. So I told them we will just, you can see the fracture. So correct the fracture and put intracorneal fat so that the volume will corrected and will get a good alignment. So this was his picture after the procedure. This is one patient which I like to share. Bilateral retinoblastoma, status post enucleation of the ball implant in childhood. Right eye had implant extrusion. So status post DFG also in childhood. So he was under a follow-up since last almost 10 years. So this was his appearance, which he was not very happy. Now he is doing his degree courses. So his concerns, like, he doesn't have a lid crease. Eye look proptotic. And eye is not closing at night. The thing is, while he was traveling in the train, somebody has picked up his keeping eyes open. So then what I did is, like, I just debugged the orbit fat a little bit. I did a frontalis sling with silicone for the ptosis just to form a small lid crease, and for the lower lid again with same silicone I did a tarsal. I did a lower lid sling starting from middle canthus to lateral canthus. So eventually he did well. So he's all right. DFG complications, poor healing and lash growth can happen. Then this is one case which I like to share. All the patients does not require any big surgeries. Again depending on patient's expectations. So he's an auto rickshaw driver. He just wanted shell to be in, but still that was also not going in. So I did a small lateral tarsography so that the shell will stay inside. So this is his picture post customized prosthesis and a lateral tarsography. And he had already received radiation, etc. So none of the surgeries is going to work also. Colored iris is also possible. A few words about congenital anophthalmos. The rehabilitation should start at birth. But most of the time, even if we tell the parents, like, no, they won't agree most of the time. They will just go from this place to that place, etc. So implants usually done less than 5 years, dermis fat graft. If the socket is contracted, you have to use orbital tissue expander, which I don't have much experience regarding tissue expanders. So this initially we start with progressively enlarging conformers. First expand the lid, conjunctiva, then you can give the volume to the patient. So this is one patient presented to us, like, I think 5th day of life, had a huge cyst with anophthalmia. So initially the shell was also not going in. So just waited till 5 months for anesthesia. Then we started putting serially increasing. Actually we made a customized prosthesis and started increasing it. And now, then later she underwent dermis fat graft, and now she's like almost 12 years and she's doing fine. The only thing, like, if you look at the lid, lower lid is fine, the upper lid is still short even after doing all these things. So congenital anophthalmia, initially sometimes the shell, nothing will go in. You cannot see also. You have to confirm with ultrasound whether any ocular structures is there or not. Then put a butter conformer, review the patient every month, serially increase. Someday you have to do a lateral canthotomy also to even to fit the button conformer. So I would stress the importance of protective glasses, polycarbonate CR39, full frame, photochromic tinted, and optical modulation. Sometimes if there is some volume deficit, you can mask with plus glasses. Psychological counseling is also very, very important. And take home message, assess the socket carefully. Reconstruction is a complex undertaking. Surgical techniques are continuing over a period of years. And the socket patients are always, once they are your patient, they are always your patient forever. So decisions is between the patient, family, and the surgeon. Poorly fitting prosthesis is always a problem. And the most important thing is always protect the normal eye. Thank you.
Thank you so much, madam, for making socket reconstruction look so easy. And thank you for doing the marathon talks in the other halls in here.